The second stem of Core 1 and Stem 11 altogether refers to groups that are experiencing health inequities. And you can see here we've got listed 6 different groups who are all currently experiencing their own health inequities. And if we look over here at the Learn 2, we need to research and analyse Aboriginal and Torres Strait Islander people plus one other group. So the other group we've chosen is the socioeconomically disadvantaged people. So what we will do, we need to look at actually what are the inequities, so that's the nature and the extent. So the extent referring to how bad, what sort of numbers are there, the determinants that cause these inequities, and also the third question there, or the third aspect, is what role can individuals, communities and governments play in addressing these actual inequities. So before we get into the actual information, we just need to look at actually what is an inequity. And as you can read here, it's just something where, or a situation where there is things are not equal, they're not fair for everyone, and as a result of these inequities, people's level of health is lower. So there's 2 words that get used here: inequity and inequality. The inequality is where people are suffering from higher disease rates and things like that. The inequity is if they're suffering that inequality because of conditions that are not fair. So what this syllabus has identified is that there are certain groups, and these are the 6 groups listed here, that are experiencing lower levels of health because of situations that are not fair. They're not meeting social justice principles. All right, so if we now move straight into the Aboriginal and Torres Strait Islander people, we look at nature and extent of the inequities. You can see here some specific examples given here with life expectancy, mortality rates and infant mortality rates, where Aboriginal and Torres Strait Islanders are significantly worse than non-Aboriginal and Torres Strait Islanders. And we've got this little table here which compares death rates down the bottom left for Aboriginal and Torres Strait Islanders for particular conditions, CHD being coronary heart disease there, and that compares them to the death rates for non-Aboriginal and Torres Strait Islanders. And you can see there it's a significant difference. So there are massive inequities in this population group. However, it is worth noting, this point down the bottom, that mortality rates have decreased in some areas, and the gap between Aboriginal and Torres Strait Islanders and the non-ATSI infant mortality rates is closing and has closed significantly over the last 20 years. Now, just having a look, I've just put this graph in just to give you an idea of the distribution of ages of deaths. On the left here, we have the breakdown of Indigenous deaths, so Aboriginal and Torres Strait Islanders, and on the right is the breakdown of the non-Aboriginal and Torres Strait Islander deaths. And you can see here, if we look at the right, the non-Indigenous graph, nearly 80% of all deaths are where people are aged 65 or over. Whereas if you compare that to the Aboriginal and Torres Strait Islander graph, you would probably only say, sorry, I just skipped ahead one there, you would probably say there's about 25 or 30% max of people who are aged 65 and over who are dying. So that means that people aged 64 and under, of that people, there's about 70, they make up 70% of all deaths, which is a pretty alarming statistic. And you compare people in this young age bracket, 0 to 24 and even 25 to 44, that is a massive, if you're talking nearly 40% of Aboriginal and Torres Strait Islanders will die before the age of 44. That is a pretty alarming statistic. And again, another cause for concern and an example of the inequities that are going on in this population group. Now, looking at the determinants, we've broken them up into 3 specific areas: socio-cultural, socioeconomic and environmental. So the first one, socio-cultural. These are factors someone's exposed to as a result of the culture they're brought up in. In this, as you can see here, in this context, we're talking specifically to race, the Aboriginal and Torres Strait Islander race, but that's not always the case. Sometimes culture, socio-cultural can be what actual area of Sydney you live, what financial situation your family is in. So it doesn't specifically have to be your race, but in this instance it is. And some of the determinants that Aboriginal and Torres Strait Islander people are exposed to, well, you can read through them here. I've given you 5 there, and they obviously, what happens with these determinants is they can impact on people's health, and these particular determinants have a pretty negative impact on people's health. The socioeconomic determinants, which basically relates to money and the like, are pretty significant. And when you bear in mind this point here, where the WHO said that the greatest barrier to good health is poverty, you can see how how much of a role the socioeconomic determinants play in a population's health. And again, we've got some specific examples down here of what the actual determinants are, and you can read through those yourself. The last determinant is environmental, so more or less the physical environment that a person lives in. Some examples here, you can see these relate specifically to this population group, and you can read through those ones. But obviously they're all going to have their own impact on health and the health status. And obviously in this instance, because these groups are experiencing inequities, the impact on health is going to be a negative one. So those three different sets of determinants all play a role in the fact that this particular population group is suffering from inequities. Their level of health is not equal due to these situations, and some of them are social justice issues, so therefore that's what makes it an inequity, because it's not fair. Now, what role can communities, governments, individuals play in addressing these actual inequities? We've broken up into three sections. So the government, we've got two agencies. This is just an example. This is not the only agencies, but just an example of three different agencies here and what they actually do. And we've also got just a little little picture here of the Aboriginal and Torres Strait Islander health system. So down here, down at the bottom, is the actual health services that are given to or accessed by Indigenous Australians. Up here is sort of the federal government, that's represented by the light brown. The state government would be these ones in the middle. They pass on to sort of local community groups, which then pass the resources, etc., on to the actual people themselves. Okay, and bear in mind that's Wellington, as in Wellington, New South Wales, not Wellington, New Zealand. Just a couple of examples here. All of these are in New South Wales, except for the Kimberley, which I believe is in Northern Territory, but that's neither here nor there. So that's just a pictorial example of the Aboriginal and Torres Strait Islander health system. Now, community groups. So we've got these different groups. These are the actual government agencies, but they work with community groups to actually improve Aboriginal health. One of the biggest problems is that traditionally Aboriginals have not accepted outside help, and when I say that, I mean Aboriginals living in missions or in remote communities deal with their own health problems themselves, and they don't really accept Western medicine as such. So these groups have to work with the communities to try and educate and train Aboriginal people to be able to treat their own, and that's what's needed in terms of making some sort of dent in this or improvement in Indigenous health status. So just some local community agencies are given here with the Aboriginal Community Controlled Health Services and the medical services. And if you just have a read through of that quote, it's sort of going along the lines of the holistic concept of health, but specifically applied to the Aboriginal culture. And that's something that needs to be considered when administering health to their particular culture. And lastly, the individuals. So we're trying to provide education and support for individuals, increase the number of Aboriginal health workers and community support workers and medically trained staff. So again, just alluding to my previous point of where Aboriginal in the community actually will respond to their own people, and they will take health advice better from them rather than a non-Aboriginal person an outsider coming into the community. And again, they're trying to, you see here, increase community capacity by empowering individuals, which is going sort of along the lines of the Ottawa Charter there. That's not really specific to Aboriginals. That can be any particular population group, but we're just applying it to Aboriginals here. And just some initiatives here which individuals have been encouraged to undertake, and Healthy for Life program. Just are all sort of examples of how individuals can help to reduce these health inequities that are suffered by Aboriginal and Torres Strait Islanders. The second group that we look at is socioeconomically disadvantaged people. This is what socioeconomic disadvantage is, so the existence here of these particular factors. Now, the national extent of the inequities, socioeconomically disadvantaged people, you can read through here, but pretty much any disease, they are more likely to suffer from it at higher rates than or than people from a higher socioeconomic status. They are particularly affected by lower levels of education, and this in turn, leads to lower paying jobs, which in turn leads to a lower income, which in turn, leads to less money to spend. So often, healthcare gets neglected because it costs money to go to the doctor, or it can cost money for the medication. It's time, they might not have the time because they might have to be working to support their family and so on. And that's a cycle, and then the kids grow up in an environment where education does not have a priority, and that in turn leads to them not achieving what they need to achieve educationally, which then in turn leads to them not getting jobs where they can be highly paid. Just a point I want to make is it does not mean everyone from a low socioeconomic status has lower health status. Right? We're just saying in general, the statistics are telling us that in general they do have a lower health status. So there's a lot of determinants that lower socioeconomic people are up against compared to people from higher socioeconomic backgrounds. So it's very hard for them to lead a healthy lifestyle due to these determinants. So we have a look down here at the determinants, and you can read through those here. But they all these things contribute to a lower socioeconomic status, and then that increases the person, or the likelihood of someone to have these things. These determinants: reduced access, limited resources, and you can read the rest. Over the page, there's more determinants, and people growing up in an area of lower socioeconomic status are more likely to be exposed to an environment which has these sort of behaviours going on in it. And just here, this is an example of sort of the cycle I was talking about. You can read through that example, but bad socioeconomic status can lead to poor health, just the same as poor health can lead to lower socioeconomic status, and it just spirals from there, and it's an ongoing cycle, and it's a very tough cycle to break. And what can governments and communities and individuals do? Well, government, here we've got the Medicare and the PBS scheme. We will learn more about them in a few dot points' time. But here's some specific areas where the state government is targeting, particularly in reference to lower socioeconomic status people. Communities and individuals have been grouped together here. So the government, for those the government strategies which are here, if they're going to be successful, they need to be delivered to the most disadvantaged communities. We want to reduce the exposure to risk factors, which goes without saying. But in delivering those strategies, it's about education and prevention. And as I mentioned before, education is not generally too high in the lower socioeconomic status people. So that can be a problem in itself. But we need, what the government is trying to do is have a community-based health workforce, so that, again, like I mentioned with the Aboriginal people, if the workforce is in the community, sort of resources are more evenly distributed, and it's a little bit easier for the community to care for those who have lower levels of health. It's also a way of assisting in the prevention of risk-taking, so hopefully down the track we'll have lower levels of disease. And most importantly is this point here: these services need to address the actual causes. So there's no good just funneling money into these lower socioeconomic status people and saying, okay, let's fix your health problem. You have to actually fix the cause so that it doesn't keep recurring and happening generation after generation. That in itself is probably the biggest challenge in addressing this particular health situation. But anyway, that's quite a long summary, I suppose, of this particular dot point of groups experiencing inequities.